Hello, my name's Martin. I'm one of the tutors at Chrysalis courses. I'm going to be taking you through the component 4, Understanding Depression and Human Relationships. In Module 4 in particular, we're going to be covering depression, symptoms of depression, treatment and diagnosis, counselling approaches, risk assessment, suicide, and ethics, the therapeutic relationship. Depression is a very common diagnosis and affects all genders, social groups and ages. Statistics show up to about 22% of people in the UK will be affected, with 16% prescribed antidepressants. Formal diagnosis in depression is through some assessment tools that you may well be already familiar with, as well as your placement organisations where you'll be doing your placements in Year 3. Some of the assessment tools consist of the DSM-5, the ICD-11, which is the British version of the DSM-5, the BDI, the Beck's Depression Inventory of about 30 different criteria for presenting symptomologies. There's the Core 10 assessment, as well as the PHQ-9, which you would already be familiar with from Year 2. Your placement organisations would all be familiar with a process of assessment and may use one or more of these different types. We're moving away from endogenous and exogenous distinctions of depression and their causes. It is usually best to remember that it isn't so much the initial sensitizing events that are significant in the manifestations of depression, or any particular vulnerabilities or propensities to depression internally either, and that there is no real consistent research to date to suggest that depression has any significant cause in either of those endogenous or exogenous distinctions. As a key focus for therapists is to focus on the here and the now in terms of the presenting symptomologies and how we can help our clients work through that depression. Really focusing on coping mechanisms, coping strategies, looking at cognition, looking at behaviours, and helping clients adapt to their environment and adapt to their social life. There is no blood test or physical test that can diagnose depression, and we're going to focus now on the categories of depression as explained by the DSM-5, which covers 8 specific disorders. Disruptive mood dysregulation disorder is a diagnosis for children under the age of 12. It was previously diagnosed as bipolar. This would be particularly relevant to any students that may be on Place to Be or children placements. There's also a major depressive disorder, including major depressive episodes. The DSM also looks at persistent depressive disorder, which was previously called dysthymia and lasts longer than 2 years. There's premenstrual dysphoric disorder, substance medication-induced depressive disorders. There are also depressive disorders due to another medical condition, which includes depression as a side effect of medication. Other specified depressive disorders can also be diagnosed, and unspecified depressive disorders would consist of anything outside of the specified depressive disorders, all of which can only be diagnosed by a GP, psychologist or psychiatrist. These diagnoses should not be referred to by counsellors or psychotherapists, as it is really beyond our jurisdiction. Attention really should be given for us as therapists to the duration, timing, and presumed underlying causes, along with a focus on levels of severity. And I think that can give us an insight into how to help clients address any improvements or any worsening symptoms that we can use to identify any referrals that we can take to the GP. So what are the symptoms of depression? Well, the DSM-5 looks at the depressed mood and loss of interest as a criteria, as well as any changes in appetite, energy, sleep, concentration, feeling agitated or worthless, and suicidal thoughts. Other symptoms outside of the DSM-5 can be included around headaches and stomach aches, other aches and pains, less enjoyment, neglecting responsibilities and personal appearance. One of the things I commonly see with depression is clients who stop looking after themselves. They stop showering, they stop washing, they stop changing their clothes. They can also have difficulty making decisions, feelings of irritability, feeling apathetic, hopeless, negative, guilty or anxious. It's very important when you're working with clients with depression to really listen to their lived experience. Quite often we have therapists working who have not had a personal experience of depression, and I think this is a very important thing to focus on, is that we're very focused, very person-centred in listening to our client talk about their lived experience and their personal experiences of what it feels like, that those very dark places that depression can take our clients. It's also very important to resist that urge within to think that the client needs to do something to move forward. Depression is a very difficult, sometimes a very difficult situation to help a client through, simply because sometimes the therapist cannot relate to those lived experiences. Lots of active listening skills and lots of core conditions to help that client feel validated, listened to and understood. Very important. I'm going to go through the diathesis stress dual risk model. Diathesis refers to the vulnerability or predisposition to difficulties and negative well-being. I'm going to take you through the top line of the resilient individual. People who have a very strong sense of self-identity and self-worth, for example, who can live through very negative environmental experiences as well as positive, maintaining resilience and stability in their emotional regulation. If we take a vulnerable individual, in this case a depressive individual, their lived experience is very much where negative environmental experiences create a negative outcome or a negative sense of well-being. And as those environmental experiences improve, they become more positive, so too does the depressive's individual experience begin to improve. Sometimes when I'm working with clients, they may present with depression because they've lost a job, and the depression can be linked to that, but there may be predisposing issues within the client to make them more vulnerable to those kinds of losses and experiences. And I think it's very important to remember that when you're working with clients with that kind of experience where they've lost a job or lost a relationship, lost their career, lost their finances, is that as soon as those external experiences come back, they may begin a new relationship, they may get a job, is that the depressive symptoms disappear. And one of the things I discuss with my clients is how they might manage in the future if, hopefully not, but if they did lose those external situations like relationships or jobs, how they would like to cope with that, and would they be able to see the signs of depression coming so they could put strategies in place to support them through it and seek support. And I think that's a very important point to make, is that some individuals are more vulnerable to negative life experiences than others. Treatment in the UK has 4 steps to it. I'm going to start with step 4 at the top and work my way down to step 1 and talk about the focus of the interventions and the nature of the interventions. When you're working on placement, you will be coming into contact probably with clients presenting with depression, and they will be presenting with different severities of depression. While you're on placement, you would be supervised, and you will have a placement manager, people that you can connect with and seek support as necessary. But you may be working in a multidisciplinary, multi-dimensional way with your client in terms of working through the placement in conjunction with other support services. So let's have a look at step 4 first, where we may see a severe and complex depression with risk to life and severe self-neglect. The nature of the intervention here may be medication, high-intensity psychological interventions, possibly electroconvulsive therapy, crisis service, combined treatments, multi-professional and inpatient care. These would obviously be done under strict supervision with you, and it's very important to be mindful of if you ever feel that there are presenting symptomologies that you have trouble coping with yourself, is to bring this to the attention of the supervisor or the placement manager, and obviously keeping Chrysalis and your Chrysalis tutor, up to speed with what's going on for you. Step 3 would be a persistent or sub-threshold depressive symptoms or mild to moderate depression with inadequate response to initial interventions, and it may present with moderate or severe depression. Again, there may be interventions such as medication, high-intensity psychological intervention, combined treatments, collaborative care, and referral for further assessment and intervention. Step 2 would be where there would be a presentation of persistent sub-threshold depressive symptoms and mild to moderate depression. And there would be low-intensity psychosocial interventions, such as looking at kind of like social adaptation, social strategies to support the client develop a better positive cognitive self-perception about themselves. There would be psychological interventions, medication, and referral for further assessment and interventions. You may be working with Step 1 clients where all known and suspected presentations of depression, and the focus would be on the intervention around assessment, support, psych education, active monitoring and referral for further assessment and interventions if necessary. But again, these kinds of like interventions and focus of the depressive symptoms would be worked with you under supervision, so you would always be supported. Focusing on Step 1, we'll look at all known and suspected presentations of depression. Nature of interventions might be assessment, support, psych education, active monitoring and referral for further assessment and interventions. These are kind of like, familiar steps that you would already have been familiar with working with many clients. So we're now going to look at the factors that increase the chances of experiencing depression. We're going to look at the history of relationship problems, stressful events, chronic and acute illness, personality, drug alcohol dependency, and family history. Many clients that present with depression may also present with a history of relationship problems, which can compound the feelings of inadequacy, inferiority, that can contribute to those feelings or exacerbate those feelings of depression even more. Relationship problems can include difficult relationships with parents, for example, in childhood, with siblings, with authority figures. There may be abuse issues in the background. There may also be problems with feelings of inadequacy and inferiority from school experiences, from being with peer groups, feeling that they don't belong. These perceptions are very important to analyse and have a look at and reflect with the client in order to develop more positive and healthy perceptions about themselves. And I think the key thing here is to talk with your client a little bit about rejecting those belief systems, those perceptions that are just not true. And I think taking a really strong focus on how our perceptions can be affected by the depression or can make the depression even worse. Stressful events, traumas can be a significant part of working with depression. I would, in my personal experience, I've worked with clients who have experienced a lot of loss and separation early on in life, and these can be very much triggered by the depression. Sometimes it's difficult to tell whether something from the past is creating the depression or causing the depression, or whether the depression is causing thoughts or excessive thinking about those past experiences. But it's very important to try and get that in perspective with the client so that they can identify those patterns and maybe put into place self-monitoring strategies and identifying strategies perhaps to divert or distract themselves from those negative cycles of thinking. Chronic and acute illness can be a major influence in clients' depression. I've worked with clients in particular around chronic pain issues like fibromyalgia, hypermobility issues, MS, and also things like diabetes and cancer, where any chronic and acute illnesses can actually feed into those sense of low self-worth, self-esteem, low self-perception. Personality types. This is an interesting area to identify with your client the type of personality they actually are, or they've actually become through the depression. Personality types can look at personalities that are either introverted or extroverted, personalities that are very thinking and cognitive compared with personalities that are more feeling oriented, and also clients who have a very internalized perception of their life. Sometimes people who have more extroverted personality types are often a little bit more resilient to depression and can actually do things more in their social environment, whereas people who are introverted tend to be focused on the inside, and talking about balancing those personality traits a little bit can actually help our clients come out of the depression a little bit more and see a little bit more purpose and meaning in their lives. Drug and alcohol dependency is a very strong symptomology around depression, may be considered a comorbidity. Sometimes it may be a case that drug and alcohol dependency in the past has actually created a greater vulnerability and predisposition to depression. And also it can work the other way around, that depressive clients can actually find a little bit more comfort and soothing in drug and alcohol use, but unfortunately it can spiral into greater and deeper use of drug and alcohol. And these kinds of issues need to be kept in perspective to help the client come to terms with what kinds of things they can do that can assist them in reducing the depression by reducing the drug and alcohol dependency. And this is where I've worked with some clients in conjunction with other service providers such as Alcoholics Anonymous and drug use services, where we've worked in cooperation in order to help the client stay in sobriety while working through the deeper work you can do with them in terms of their cognitive and behavioural symptomologies. Family history is very important. In some families there can be depressive ancestral issues that can come down through the lines. I've worked with children who have presented with depressive symptomologies in the classroom as well as in their lives in general, and quite often it's related to the experiences of a mother or father that is experiencing depression at home, and those attitudes, those moods can actually be internalized by the child, and this can contribute to a kind of like a predisposition to further depression later on in life. So some of those buffers against depression. I think one of the most important things as a therapist when we're working with depression is to maintain a very supportive and core conditioned support for the client. A lot of depressive clients will come in with feelings of self-judgment, that is something inside them that's the problem, where people may say to them, pull yourself together, cheer up, which, are not helpful at all for the client, and the client needs to develop a kind of like an exploration of that and what they think is supportive therapy and what is supportive to them to help them through the depression and alleviate those symptoms rather than make them worse, which sometimes is what society can actually do for clients. Strong supportive relationships. As the therapist, you are in a position to actually create a strong supportive relationship for your client. And I think this is where those kinds of approaches with one's client to help them internalize that there is someone there that does care, that does support, that is willing to listen, that there is something within the client that creates a feeling of somebody values myself. And I think these kinds of relationships are very important to help clients develop a greater sense of positive self-worth, and the therapist is in a very good position to help them internalize those feelings of self-worth. A strong support group can be very helpful. Obviously, in some cases, clients do not have any support network around them, which makes them more vulnerable to depression. Sometimes it's very useful to talk with a client about the kind of support groups that are out there, but not just focused on mental health support, but also social groups, sports groups, exercise, getting out there into society, finding more meaning and purpose, hanging around people that are like-minded in terms of wanting to improve themselves, people that are kind of like much more proactive. Some clients will venture into justice causes. Some clients will venture into helping other people with similar symptomologies, working with young people especially, to help them feel as if there are other people who've gone through the same situation as them and have come out the other side feeling stronger and much more resilient to their presenting symptoms, and that there is actually light at the end of the tunnel. Meaningful and regular employment is one of the most important areas. It's about focusing on something that you've done or you can do, or you have a skill or gift in that you can take into the world to serve other people, to help other people, are very motivating activities that can bring greater self-concept, greater self-esteem, and a greater self-identity. These meaningful and regular employment is something that I've studied with rank theory, and I found this very useful, which was a study of young men with experiencing depression. And the reason it was called rank theory was because a lot of the depression that manifested in young men especially was related to a lack of work and a lack of purpose and meaning in their lives. And I think this theory helps young men especially, and young women, find that there is a great meaning and purpose in our life experience, and that there is something in life for all of us to have a place in, that we all have a gift, we all have a talent, and we all have a purpose and meaning in life and for our communities and our society. Something that I think our culture actually takes away. A healthy diet is very important. I had a client who came along talking about his symptoms of depression, and I said, and I asked him, where did the symptomology actually begin? And he said, about 3 months ago. And I said, what changed about 3 months ago? And he said, well, I just stopped eating. And I said, how about you start eating the way you were before? And I said, tell me a little bit about your diet back then. And he talked very much about healthy vegetables, healthy fruit, healthy creating food from scratch, no processed food, no kind of like junk food. And I said to him, give yourself 2 weeks, go away, change your diet, then come back to me in 2 weeks and tell me how it's going. And he came back to me and said the depression's gone. So it is possible to actually reverse depression at a very early stage. I would have thought for this guy, had the diet not been addressed first, or any kind of like physical symptomologies such as hormone issues, thymus gland issues, they're kind of like a really good way to go to first and get the GP to check those out, and then you can work on the more psychological kind of like social issues. But I think it's very helpful to go straight for the biological causes of depression first, because you can save a lot of time and maybe a lot of long-term damage if the depression isn't addressed at an early level, at an early time. Good quality sleep is really important. Get a nice picture of where your client's sleep hygiene is. Generally 6 to 8 hours. talk about dreams, talk about what they do just before they go to sleep, talk about what they do as soon as they wake up, because you'll be able to spot some of those habits that may be feeding into the depression. Regular exercise, I always go through a very strict kind of like regime with my clients on around depression, and we talk a lot about exercise and vitamin D, being out in the sunshine. Sometimes you get clients presenting with depression who may have SAD. I always recommend the sun lamps. They're not expensive. Just about 15-20 minutes in the morning can really get the clients in a more positive frame of mind. In my own case, I used to put an orange cloth over my lamp. Okay, and regular exercise I always recommend with my clients to have a look at their exercise regime, as this has a massive impact onto their depression and well-being. Quite often I find that clients that get into sports activities, jogging, walking, getting in nature, can really make a big impact on their depression symptoms. Again, going back to the strong sense of purpose for their lives, job, work, service, helping with their relationships at home, finding a stronger purpose of relationships with their family, with their relatives, with their children, with their parents, with their colleagues, if they're working. But I think that main focus on relationship, that relational connection with people, is probably one of the most powerful methods of overcoming depression and finding that sense of belonging in their society, belonging in their community. If there are aspects or difficult aspects in their family lives where they do not feel they belong, it's talking about ways and communities and places and environments where they can go to find that sense of purpose in their lives in relation to their belonging and their relationships with people. An ability to live more in the moment rather than feeling stuck in the past or feeling anxiety about the future. We'll go into this in a little bit more detail. But that ability to live now rather than in the past is a very powerful way of getting clients to realize that we are made by the decisions we make in the now, not by the decisions that happened in the past, and try to encourage clients to really focus on the now and the future, and that all the decisions we make in the now will have a positive impact on our life situation and our life potential. An ability to develop helpful coping strategies for stressful situations, including identifying triggers towards depression. This is an important part of depression work with clients, and there are always going to be stressful situations that trigger our feelings of low self-worth, and talking them through and finding other ways of reacting to situations is extremely helpful to get clients to overcome their difficulties in life situations. Communication, assertiveness and boundaries are essential components of good depression support. An ability to identify and deal with internal stressors that might be operating within the individual. Internal stressors are the ways we think about ourselves in our lives, and identify areas where we can reframe those with our clients. So this is one of the models that I use very much with depression and anxiety clients. It's the negative triad by Aaron Beck in the CBT approach. I find it very useful in many forms and many presenting issues for counselling. And it very much focuses on the negative view of the self and actually asking your client, can you tell me what your negative perceptions are of yourself, what your negative views of the world are, and what your negative views of your future is. I also include in that your negative views of other people or other people's negative views of yourself. It really gives a deep insight into how the client is actually thinking, and gives you a great deal of potential work for reframing that. And I implant over that the positive automatic thinking triad, where I ask the client, right, now I need you to help me see a kind of like how you would reframe that into a positive view of the self and reject those old, faulty, maybe distorted or irrational thinkings about yourself, other people and the world and your future. And clients can get a great deal of benefit from that. In some cases, clients may present with you, I've got nothing positive to think about myself, there's nothing positive there. And I often take clients out of themselves in that situation, and I turn around the situation with them and ask them to tell me if they knew somebody in their family or a friend that was presenting with all these negative views about themselves and the world, and ask them how would you help them support that. And they come back with some very positive reframing about that. And then I suggest, well, how would you like to take that and transfer that to yourself, and how you would like to change? And I find that a much more positive way of moving into the client, trying to change some of those very negative views about themselves and the world. The negative self-schemas can be very much more entrenched and based in past experiences, and so reframing needs to be a very repetitive approach in the process of working with depression. So in every session, going back to those negative self-schemas when they arise and working towards reframing them. It isn't just a cognitive thing, it's very much about social adaptation and asking clients, well, if you take this new positive feeling about yourself, what would that look like in a situation at work? What would that look like in a situation where you were conversing with somebody? And then asking the client, is it possible for you to go out into the world, identify a situation where you would normally be very negative, and then replace that or reframe that with a more positive approach, and then come back to me in the next session and talk about that and journal about that. And that can be very productive, meaningful, purposeful work. So it's not just cognitive, it's about behavioural change and changes in their lifestyle. So using the person-centered therapy approach around depression. So we're often always looking at how incongruence exists in the depressed individual, and we look at the differences between the concepts of the actual self, the ideal self, and the self they think they ought to be. And it's very important to try and get a picture into the client's awareness of what they see as their actual self, the depressed self, the self they would want to be, the ideal self, and what that actually looks like in terms of not just cognitions, but also behaviours and attitudes and interactions with people in the world. I think it's very helpful to look at that ideal self and the self that they want to become, because it really helps them identify goals and those small steps that they need to achieve in order to make those changes from their experienced self now to the self they would like to be. I think it's also very important to be congruent with the client's incongruence with themselves, because some clients will feel in a very negative perception of themselves, but it's not possible to actually change that overnight in terms of overlaying I feel good when they don't feel good. Is to really identify that incongruence, be congruent with the incongruence, be congruent with that, with those negative perceptions and those negative emotions, and move forward into ideal or selves that they would like to become, and start to help them see that there is light at the end of the tunnel, that there are other ways of being. It just takes a while for the emotions to catch up. Examine the client's self-concept and conditions of worth. This is very important in person-centered therapy to help the client become more aware of their self-concept, who they think they are, why they think they are, the conditions of worth that they've internalized and introjected from experiences to make them who they are, and to move forward into rejecting those that are not true, to move forward and reject those beliefs and cognitions that are just no longer helpful anymore. The core conditions and safe supportive relationship that you can create with the client will benefit them enormously. Where clients have had very negative relationships in the past, they are going to feel very They're going to have introjected those values of low self-esteem, low self-worth, inferiority, inadequacy. And simply by being a therapist in your therapist role and providing that valuing dimension to the relationship, they will internalize that and begin to think there is someone here who listens to me and validates what I say. It's not about saying you're going to be good, you're doing great. It's about saying to the client, what do you need to hear yourself say to yourself? What do you need to hear yourself encourage yourself to do? And so you're empowering their client by internalizing a locus of evaluation that is within them and not within the negative judgments and assumptions of people in their lives where there has been mental or emotional abuse, for example. In exploring the client's world, we may find distressing intrapersonal processes, overly self-critical aspects. And I think this needs to be made conscious in the mind of the client, where clients can be incredibly self-critical and self-judgmental, and exploring how this actually affects them in their own functioning in the world, and to work towards changing that and finding those positive things, those positive traits within the client to help them move out of those negative automatic thinking loops. So ethics when clients are actually at risk. So if a client is at risk of suicide or serious self-harm, I think it's very important to always acknowledge that you are never working in isolation. You are working within a placement organisation. You have a supervisor, you have a placement manager, you have a chrysalis tutor, you have your peer group. You are very supported, and it is very important to approach that support when you need it. It is not considered an inadequacy or a lack of professionalism in the therapist if they call out for help. I actually consider it a strength in the therapist to actually step forward and say, can I have some support? Can I talk about this client? I need some extra expertise or advice. And I think that's how we become better therapists, by being more collegial and admitting when we may need to have some extra CPD, do some more research, do some more reading, because there's a huge amount of support out there that therapists, especially in the first few years of their practice, they need lots of support and they need good supervision. So whenever a client presents with suicide or self-harm, talk about it and get that assistance. There's on Moodle, students are encouraged to watch the suicide video, which is very supportive with ideas to help your clients, and it's very important to watch that before you go on placement especially. What has the client given me permission to do? Well, this comes down to your contract and your confidentiality agreement. It's very important that the client knows right at the beginning of therapy when you can breach confidentiality, such as at risk, if they are at risk of harm to themselves or others, or if they are at risk from other people. I've worked with a client in particular who did present with suicidality, and I was very concerned about. I spoke to him in our session and I said to him, would you like to see your GP and raise this further, or would you like me to ring on your behalf? And he did ask me to ring on his behalf, and I did ring the GP and I flagged up the situation with him. And the following morning my client was in the GP surgery and was prescribed diazepam, a very short-term treatment, but my client came back to me and said, I felt so much better after I did that, I couldn't have done it on my own. It is very stressful sometimes, and it's very worrying working with clients with suicidality, but it is something we do, and it is something we sometimes need to get used to. And it is no reflection on the therapist if we do need to contact the GP. I would always say best to be safe than sorry, and follow through on all of those possible support networks that are available, because GPs will respond to a call by a therapist. I would also put in there that there may be times when you may ask a client whether they would like to speak to the GP about something like this, or whether they would prefer you, and they may say no. but your concerns for them may still be there. In that case, you go straight to supervision, you speak to your placement manager, you go through the policy procedures and the safeguarding procedures, and sometimes we do have to contact, even without the consent of the client, if we think they are at risk of suicide or serious self-harm. So that may mean that you may lose them as a client, but in saying that, I would always recommend all decisions to be made under supervision, and in case of more serious issues is to contact your professional association for advice and guidance, because there is always support for you out there. If I refer, what is likely to happen, I've gone through some scenarios. It's very important to remember that sometimes making a referral means you can lose the confidence of the client, but you may give them the opportunity to take further support. And this is very important, that it's the client's safety that comes first. And I think it's also important to remember that when you're referring is that you do it with the full knowledge of the client, so they know what you're doing and when you're going to do it. If I do not refer, what is likely to happen, we have to think those questions through under supervision. And again, don't feel that you have to make those decisions and choices on your own. Always do that with support. Do the likely consequences of non-referral include serious harm to the client or others? Yes, sometimes it may mean that if we don't do anything, that serious harm could happen. So again, supervision. In all of these scenarios, supervision is the key. Are the likely consequences preventable? We're going to have to discuss that in supervision and then set a kind of like a procedure or an action plan. Is there anything I or anyone else can do to prevent serious harm? There are other support providers out there. There are other services. Please be mindful of what they might be and whether you may need to ask clients to approach them. What steps would need to be taken? Again, very clearly, we go through supervision. How could the client be helped to accept the proposed action? In all cases, I think it's always best, but 100%, to be open and honest with the client in what you're going to do and when. Does my client have the mental capacity to give explicit, informed consent at this moment in time? In some occasions, no. Some clients may be so fogged up with emotional dysregulation, suicidality, that there may not be the informed consent there, in which case supervision and then go from there. If the client does not have mental capacity, then what are my professional responsibilities to client and in the public interest? Again, we'll come back to supervision and find a way forward through an action plan. If the client has mental capacity but does not consent to my proposed action, e.g. referral to a GP, what is my legal situation if I go ahead and do it anyway? If you were to go ahead and do it anyway, you would have done that under supervision. And remember, the code of ethics is always to do no harm. And if you're not doing any harm, then sometimes, you have to follow that through. So a risk assessment with clients with suicidality and self-harm is a contract stating when to breach confidentiality should be in place, and always make that very strongly known to the client at the beginning of therapy. Discuss with the supervisor and practice manager. We've gone through those processes. Contacting the GP, calling an ambulance or police if it's an emergency. There may be situations where you may not have time to contact the supervisor or the practice manager, or particularly if you're in private practice and you're working late in the evening. Again, you have to make that judgment yourself, and sometimes there will be support at the end of the email for you, maybe with a tutor at Chrysalis may be able to support you if your supervisor isn't there. Again, we would always err on the side of caution. Factors that might increase risk: social problems, separation or divorce, social isolation, bereavement, illness, alcohol or drug use, unemployment, and access to means. These risk factors may be there in the life of the client and are very important to take into consideration. The possible signs would be suicidal thoughts and suicidal ideation, showing serious intent. There may be a history of previous suicide attempts, a history of mental health issues, a family history of suicide or history of abuse. As these issues increase in propensity, so too does the concern for the client themselves. There are several populations that are more at risk statistically from suicide, in particular young men in their late teens and early 20s, quite often the transition from adolescence into young adulthood. The other statistical risky group are men in their midlife. There are also higher incidence of suicidal risk in women, and it's always a very good idea to identify the most latest statistical analyses of those groups, because sometimes when a more vulnerable group does step into my therapy room, if it's a young man, for example, or a young woman who's gone through serious trauma, I will be more alert to suicide and self-harm symptomologies. So ethics, the law, and good practice. Respecting culture, values, beliefs, experiences, and feelings of clients using the core conditions. Culture and beliefs are very important, depending on the kind of like the religious groups, and also BAME, LGBT issues do flag up issues or concerns sometimes, and it's very important to be aware of some of the cultural values around suicide and higher statistical research around those groups that are more vulnerable. Recognising sensitivity of material and keeping total confidentiality except for supervision required by law due to risk of harm to self or others, or subpoena by court or disclosure of terrorism or child abuse. In connection with the notes that you have to keep, always keep notes based on the facts of the client that they presented to you. Writing down the facts are very essential. Please avoid any interpretations or analyses on your part about the client and what you think they might be thinking or doing. Keep it to exactly what the client has revealed to you and disclosed to you, and write them down as facts. And this is what the client said. Keeping clear professional boundaries on presenting issues you are working with, your level of competence, level of contact between sessions, contractual obligations relating to sessions and payment, and have no dual relation with the client. These are good ethical considerations when you're working, particularly with very vulnerable people. Therapist self-awareness. Being aware of your own motivations, being aware of your understanding of your own limitations, reflecting on your own skills and knowledge, and having sufficient and appropriate supervision in place. I think there are a number of areas of this presentation where you may like to do some self-reflection work around your own feelings, around low mood and suicidality, self-harm and depression. I think it's very important to talk about those issues in your own personal work, in your own personal journey, because there are going to be times when you're with clients and they may be reflecting to you through their own lives things that you've experienced in your life, and that may be very triggering for you. And the more kind of like therapyized you are in those experiences and those perceptions in your own life, the more helpful you are going to be for your client, because you won't be triggered and fogged up by your own emotional dysregulation. This has been a very important module to take you through. Thank you for listening. Wishing you well on your journey. Enjoy the rest of your course.